morning, friends. I'm Dr. Vivudh Pratap Singh. I'm a senior intervention cardiologist at Fortis Escorts Hospital, New Delhi. I have a privilege to have with me Dr. Sripal Bangalore from NYU, USA. And today we are going to talk about some pertinent topic for an intervention cardiologist. So, Dr. Sripal, welcome to our channel and show. The first question will be when you should be considering revascularization in a patient with ischemic cardiomyopathy.
No, first of all, thanks for having me here. I think in terms of patients with ischemic cardiomyopathy, there has been a recent controversy because of the results of the REVIVE trial. But just to go back, if you go back 30, 40 years ago, we had a number of trials which tested CABG versus no CABG in these patients. Even though not specifically restricted to ischemic cardiomyopathy, those trials back in the day showed that there was a mortality benefit of bypass surgery. And interestingly, the subgroup of patients who derived the most benefit, mortality benefit with bypass surgery were patients who had left main disease. And the second subset was patients with ischemic cardiomyopathy. And the one caveat for those trials are there was no medical therapy. And then we followed that with some advancement in medical therapy. Then we had the STITCH trial, which compared patients with ischemic cardiomyopathy randomized to CABG versus now medical therapy, which included ACE and beta blockers. And even though at 5 years, which was the primary endpoint, there was no mortality difference, at 10 years, there was a mortality benefit. And so because of these, it was a class 1 indication, at least in the American guidelines, to say you should revascularize with CABG for ischemic cardiomyopathy for improvement in survival in these group of patients.
Okay. So what the data holds for the REVIVE trial and how this thing has really changed our practice in the recent time?
Yeah, I think now with the REVIVE trial, REVIVE was mainly aimed at trying to test PCI when compared to medical therapy alone in terms of whether there is a difference in clinical outcomes in ischemic cardiomyopathy. Just to be clear, REVIVE was done a decade after STITCH. And what has happened since then is there has been advances in medical therapy. So it was not just ACE, beta blockers. We had MRA and also Entresto, etc., in the pipeline for medical therapy. And it was a smaller trial, 700 patients. And in that trial, when you look at PCI compared to medical therapy, there was no significant benefit in any of the clinical endpoints tested. And of course, there was news everywhere, made it to the media saying PCI does not work. And it has created a lot of controversy. I think it's very important to put that in context because the question is it because PCI does not work or is it because medical therapy is as good? If you kind of compare STITCH and REVIVE side by side and see, is PCI actually inferior to CABG, you'll realize for the endpoint of all-cause mortality, the curves for PCI and CABG will overlap. What has changed is the medical therapy for STITCH compared to medical therapy for CABG, for REVIVE. So in other words, our medical therapy has vastly improved. My take home on why the REVIVE trial was negative was mainly because the medical therapy was a lot more superior. We had MRA, Entresto, there was greater use of ICD in that trial.
Definitely, the 4 pillar of the medical therapy, the MRAs, the ARNI, and the beta blocker, and the SGLT2 have really changed the game. But still, in your clinical practice, what kind of patient you will be taking in for PCI from the subset of ischemic cardiomyopathy patients?
Yeah, I think we have to be very clear of which patients were not included. For example, if a patient comes in with an MI and has cardiomyopathy, clearly revascularization, whether it's PCI or CABG, is beneficial. And the trials, the STITCH and REVIVE don't really apply to that. And I think that's the key take home because there is a lot of misconception trying to apply these to patients with an MI.
True.
And, I'm sure you have this. I have multiple examples of patients where we revascularize with PCI and the EF normalizes.
True.
Whereas in STITCH and REVIVE, they showed even with CABG, the improvement in EF is only 2 to 4%. So clearly MI patients, we do. In terms of what REVIVE tells me, first of all, these trials are very underpowered. And then you were talking about SGLT2s. Those trials at 4,000, 8,000 patients.
True.
Now we are doing trials at 700 patients and trying to find a difference. So, I think that's one of the major reasons we don't see a difference. But what Revive tells me is if you have ischemic cardiomyopathy, I don't need to rush them to revascularize everything. I can actually say we can start with medical therapy, but I still offer revascularization more for symptom relief, and also because even Revive showed that symptomatically they feel better, and to the fact that they can also prevent other events, including spontaneous MI in these patients.
So what will your message for the future? What we should be making some trial with more number of the patients, more real world practical data with CABG with the current status of medical therapy, and PCI with the current state of medical therapy. So what should be the future of these? Where should we lead to in the future?
Yeah, and I think that's a great question. I mean, first of all, I feel like people are indirectly making this inference that PCI is inferior to CABG based on just these two trials, and saying every patient with ischemic cardiomyopathy should either get medical therapy or bypass surgery. Clearly, that's indirect. There is no head-to-head randomized trial. So first, we need a randomized trial comparing PCI versus medical therapy. I mean, the other question is, should we revisit STITCH by including a medical therapy arm with all of the 4 pillars? I mean, there is no trial with the 4 pillars of medical therapy. I mean, we are working on some of these, trying to see if we can do a randomized trial to try to answer this question. But I think we really need that, because the medical therapy is far advanced. Device therapy for heart failure is far advanced. So I think we need to understand this better.
True. That is the essence of the whole issue. We should be taking the data of the Revive in this context. Thank you, Dr. Sripal. Thank you so much for being our guest.
Thank you. Thanks for having me on. Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.